by the experienced speakers, so so that you'll get benefited. You all know that there are many videos and books are available from where you can read the instruments. But I just wanted to give you and acclimatize you, give you the environment of how the exam is being conducted, how the instruments are being asked, and from the instrument name, you can be diverted to any topic. So such kind of experience you'll get only from the experienced teacher. So we have Dr. Ravi Meher sir. Sir is the professor, director professor at Maulana Azad Medical College. He'll be covering the instruments parts. This was previously to be taken by Dr. Ishwar Singh sir, but because of his commitments, he was not able to make it. So Ravi sir, at short notice, he agreed to take the lecture series. So thank you very much, sir. Our moderators are Dr. Avni Jain. Ma'am is Associate Professor at ESI Faridabad, ESI Hospital College at Faridabad. And we have Dr. Nitin Gupta, sir. Sir is a professor at GMC Chandigarh. So I welcome our moderators for today's session. So before starting, Avni ma'am, we have 4 residents from different medical colleges. I have given you the list. So as in when asked for, Ravi sir will be asking you to name the one of the resident. So you need to switch the resident one by one when asked for. And Nitin sir, the queries or the comments of various participants will be which will be posted in the chat box. So you need to put forth it to the speaker so that he can answer all those queries.
Right.
And I request my moderators, if you have any comments or any points for the benefit of residents, you may please add at the end of the session. So I welcome Dr. Surinder Singhal sir, President Haryana. Welcome. Sir, please unmute yourself.
Good evening, Raman.
Good evening, sir. Good evening.
Yeah, good evening, Dr. Ravi. He has gone.
Sir,
good evening.
Sir, good evening.
Good evening, sir.
Good evening, Avni. Good evening, Dr. Nitin Gupta.
Good evening, sir.
I think Dr. Ravi has been our savior many times. Eh?
Yeah.
When somebody is not available, so we ask Dr. Ravi to say.
Yes.
That's nice of him. We accepting at the last moment even.
Yes.
Yeah.
And we enjoy his teaching, sir.
Yeah, good.
Thank you, sir. Thank you very much.
Okay, we can start, I think.
So Ravi sir has some issues with the laptop. So in next 5 minutes, he'll be starting.
No problem.
So in the meantime, we can just give a brief about the importance of the instruments.
Yes, sir.
Yes. So if you talk from the PG exam point of view, mainly where I have been an examiner, the total marks are allotted are about 400 in the practical. So about from 425, approximately 25 marks are allotted for instruments. So the instruments are such that one can easily get good marks in instrument like 22, 23. So one can compensate if there is any deficit earlier. And secondly, we all know that the importance of instrument is not only from exam point of view, but also from when we are assisting somebody, like a resident is assisting somebody, he should be knowing that which instrument the surgeon is has to be given, even if the surgeon is not taking the name of particular instrument. He should be so efficient, and it will also help himself or herself while he is doing the surgery. And secondly, we know how to keep the instruments in a proper manner, then they will increase the longevity of the instruments also.
In addition, the instruments are such thing that you can divert your viva to the subject which you know best. You can divert that discussion to that, and you can take advantage of that. That is another point in instruments.
Yes.
So, sir, to start with, I would request Dr. Surinder sir. Sir, can you please tell us how the instrument viva starts? How the examiner starts the question, asking a question, whether he gives the option to the resident or something else?
Basically, the instrument tray is placed in front of the examiners, and it depends which from the college itself what instruments they are keeping. Generally, all the instruments are kept which are there in the operation theatre, used in head and neck, rhinology, otology, everything. And generally, the examiner can pick up a instrument and ask, what is this? What is the use of this? What are the procedures done with this? What are the complications which can happen with this? Or sometimes they are courteous enough to say, okay, pick up an instrument and tell us. So that's how it starts.
Right, sir. Avni ma'am, would you like to say something?
No, I think sir has covered it all. Like sir said, basically we can direct our viva in the direction we want, especially when the examiner gives a choice of the instrument, then we can choose the topic we know best and direct our viva in that direction to ensure that we get better marks. And most of the questions are objective rather than subjective. So chances of scoring are very high.
Right. Yes, Ravi sir, over to you, sir.
I don't know what to do. It's it's actually showing
You can-
you are 100% there, but please keep your computer on. That is what I can see.
Okay, okay. No, sir, sir, can you send me the presentation if you have on the
This
phone?
is actually on in the laptop only, and this actually had gone into updating. So there is a window
Right, right.
update which has started. I don't know how it started
That takes
just
time.
now.
That
No,
takes
And
time.
No issues.
I don't know what to do.
No issue.
So
You have another laptop, sir?
I have another laptop, but the problem is the presentation is in this laptop.
And it'll have to be copied from here, then to go there. In the
Yes.
meantime, it will get.
With the help of pen drive, it might be easier.
Yeah.
No, but the laptop is not. I mean, it is not switching. No? It is updating, and it says
Okay,
you are
okay.
100% there, but please keep your computer on, and that is how it is.
Okay. Okay.
Actually, my computer was also updating, so I joined late. Yeah, usually I try to join 5 or 10
Raman,
minutes before.
Hanji, Hanji, sir.
can we do you have the PPT?
Yes, I have that PPT, sir. So
You
give
can
me 5
just
minutes.
start
I'll share the I'll share the PPT. Give me 2
Yes.
minutes.
Yes.
only 2-3 GB करता है वो अभी आ जाए उसके लिए
Hello. Avni ma'am, can you please announce the name of the residents meanwhile?
Yeah.
Available here or not?
So we have 4 residents, Dr. Harsh from ESI Medical College and Hospital, Faridabad, Dr. Ramya from BPS Khanpur, Dr. Sudesh from BPS Khanpur, and Dr. Disha Saini from GMCH Chandigarh. So we have these 4 residents whom we'll be calling one by one.
Can you see my screen now?
Yes, we can see.
Right. Ravi sir, we can start meanwhile.
Okay, thank you, Raman. So we are going to cover the otology instrument first, right? So this is the first instrument is Miringotome. So basically, what happens in the as Dr. Surendra Sehgal and other speakers have told you that the instrument is a way to start your viva, right? So basically, you have to identify the instrument, and in most of the time, you will be able to identify the instrument. And sometimes the examiners ask you to pick up any instrument of your choice. So you have then choice. You can pick up any instrument, and then the viva starts on your that particular instrument, right? So it's just a way to start your viva. And first question will be, identify the instrument, and second, what are the indications. So can I know some indication of this instrument from the postgraduate students which we have here online?
Dr.
So
Harsh, please tell the.
anybody can answer.
Hello, good evening, sir.
Yes.
Is
Good
I'm
evening.
audible, sir?
Yes, you are audible.
Good evening, sir.
Good evening.
Sir, this is a Pulitzer meringotome, which can be used in acute otitis media and
Acute otitis media. Okay.
in serious otitis media.
Right.
And yes, sir. We can give a radial incision on the tympanic membrane in the anterior inferior quadrant in serious otitis media.
Mhm. Right. So basically, it is used to give an incision on the tympanic membrane. So it's a meringotome. It's a sharp instrument,
Yes.
and the indications are ASM. So in which stage of ASM will you give incision? What are the indication of using meringotomy knife in ASM?
Sir, in ASM, if the tympanic membrane is if it's in suppurative stage, if we seeing a bulging TM with pus inside the tympanic membrane in the cavity, middle ear cavity, we can
Right.
go for a meningotomy.
Absolutely correct. So basically, when you have a bulging TM and patient is in extreme pain.
Extreme pain, yes.
Yes, and patient has extreme pain. The TM is bulging and it's just going to perforate. So what you can do, you can just give a small incision on the tympanic membrane, let the pus come out, and this will relieve the pain of the patient. So that is one indication. Most of the time, we are actually treating ASM with antibiotics, and meningotomy is not necessary. But in case there is a patient with acute otitis media having complication like facial nerve palsy, right? In that case, also you can actually relieve the tension in the middle ear by releasing the pus, and in that case, you can do a meningotomy. Okay, so there is another indication when you are giving steroids, intratympanic steroids. If you want to give intratympanic steroids for sudden sensorineural hearing loss, you can do a meningotomy, put a grome, and then instill the steroid, right? So grome will actually facilitate multiple doses of steroids, intratympanic steroids, right? So that is another indication for using this knife. Suppose you don't have this knife in the operation theater, is there any alternative instrument which can be used?
So we can use a sickle knife.
Yes, you can use a sickle knife. So sickle knife is also a good instrument to do meningotomy. What is the site of meningotomy?
Sir, in acute otitis media, we can the incision is given in the posterior inferior quadrant.
Okay. Hello.
Hello. Yes, sir.
So posterior. You want to say which is the site where you don't do any meningotomy or any intervention?
So posterior superior, because there is ossicles present in there.
Right. So
in that
posterior
side.
superior part is not to be touched. You can do meningotomy in anterior superior, anterior inferior, and posterior inferior quadrants.
Yes, sir.
What is the indication of doing a meningotomy in anterior superior quadrant? Is there any indication? So basically, it depends. When you do a meningotomy and put a grome insertion, right? When the grome is insertion, how does it extrude?
Sir, the grommet is exuded by the centrifugal migration of the external canal epithelialization, which cause the extrusion of the grommet.
Very good, very good. So what happens? There is a migration of the squamous epithelium from the tympanic membrane from center to outwards, right?
So, yes,
so
sir.
what happens? The grome also keeps on moving from the central part of the tympanic membrane towards the periphery, and ultimately it reaches the annulus and it falls off. It is extruded on its own. So that is spontaneous extrusion of the grome. But if you want to put a long-term grome insert, right? So long-term meaning for more than 6 months, like for a year or 2 years, then you can actually do a groma insertion in the anterior superior quadrant, because the migration of the epithelium in the anterior superior quadrant is very slow as compared to anterior inferior quadrant, right? For example, if you want to put a groma insertion in a patient who has cystic fibrosis, or who has ciliary dyskinesias, right? In those patients, there is a recurrent recurrent attacks of serous otitis media, and in these cases, you need to put a long-term groma. And if you want to put a long-term groma, you can put it in the anterior superior quadrant, right? So that is the indication. So anything else you want to know or discuss in this? So that is all, I think, in
Yes, sir.
this instrument. But again, as I told you, the Viva can actually go from serous otitis media, then management, and then indications of the surgical intervention. So it can go anywhere, right? Initially, it is the identification of the instrument, and next we go to the indication, and then what are the complications which can occur. So can you tell me some complication which can occur because of this instrument?
Sir, it can lead to, sir, autouria. It's a
Okay.
and the permanent perforation of the tympanic membrane.
Right. So basically, using this instrument intraoperatively, it does not have any much complication if you are using it in this correct quadrant. If you use it in the posterior superior, obviously you can damage the ossicles. But if you are using it in anterior inferior quadrant, it's quite safe. Only thing is that you have to control the size of the incision. If the incision is too large, the groma might not actually fit, and it might get into the middle layer or can come out, and you will not be able to. The groma should be snugly fitting in the tympanic membrane. So that might be very loose and it might fall off, right? So that is one thing you have to keep in mind while using this instrument. Don't make the incision very large, right? So that is the thing. Okay, Raman, we can go to the next instrument.
Yes.
Just a minute. One comment. I think
Yes, sir, please.
Dr. Harsh has
Please.
answered beautifully, and the discussion was good. But the other way of doing it was, he should have gone step by step. Like, what is the instrument? He should have said, this is maringotomy. Okay. Then what is the use of it? This can be used for maringotomy. What are the indications for maringotomy? Then he should have said, acute suppurative otitis media, splenic otitis media, and steroid instillation in the ear. So if you go step by step, then you are scoring more marks. The examiner will feel that he has good knowledge of subject. The extended indication can be, what are the types of grommet? It can be a short-term grommet, mid-term grommet, and long-term grommet. So there is a huge list. There are about 12 types of 12 grommets. That list is given in Robb and Smith Otology, not in these days books, newer books. Okay, you can read that if you want.
Yes, sure.
Yes.
Okay.
So Dr. Surinder has pointed out the types of groma also, right? So we have Teflon gromas, then we have titanium gromas. There are different types, and again, the type of groma inserted will tell you, will let you know whether the groma is going to extrude quickly or it has a long term. So there are gromas which are short term gromas, there are gromas which are long term. So there's one groma which is T-shaped, right? Yes, good. Right. So that groma is actually used for long-term insertion. So if you want to do a long-term groma insertion, then you can use that. Otherwise, Shah and Shepherd, these are the simpler gromas which are available in the market. And Teflon is the most commonly used groma. We have self incising groma also available. That is basically made of titanium, and one of the edge of the groma is actually very sharp. So that simple that groma itself can be used to incise the tympanic membrane and insert it in one go. So that is also like a type of groma which is available in the market, right? So though I have not used it, but I have read about it. Okay, so we can go to the next instrument.
Yes.
Yes, again, small discussion.
Yes,
there can be practical question like, you have diagnosed the case of otitis media with the fusion. You have taken into OT. You are doing a maringotomy. You have made a incision, but the glue is not coming. What are the causes? Then
Right.
there can be sometimes very thick glue, which is not coming. Then what do? You have to give a counter incision in the anterosuperior quadrant. That is called beer can effect. Or you can instill sodium chloride or hyaluronidase. These types of things can also be asked.
Right. Absolutely correct, sir. So the beer can principle, you must know that when there is a very thick viscid secretion in the tympanic, in the middle ear, and the suction is not enough strong enough to suck out the fluid from the middle ear, then you can give a small another incision, and that will act as a air escape mechanism. So the air will actually go inside the middle ear, and the fluid which is there in the middle ear can be sucked out, right? So that can be used. Okay, so
The next instrument.
I think this enough for myringotomy knife. We can go to the next instrument. Okay.
Good evening, sir.
Good evening. So, what is this instrument?
Sir, so this is a
It is written there.
yes, a Mollison self-retaining mastoid retractor.
Okay. So, what are its indication? Where do we use this instrument?
Sir, it can be used in ears otological surgeries like tympanoplasty or mastoidectomy. It can also be used in other surgeries like thyroidectomy or tracheostomy.
Tracheostomy. You will use it in tracheostomy. Have you ever used this in tracheostomy?
No, sir, we have not. But it can an extended use of the instrument, sir.
I don't think it is a good idea to use this instrument in tracheostomy, but it can be used in thyroplasties, right?
Yes,
So when you are doing a neck incision and doing a medialization thyroplasties, you can use this instrument because this will actually help to keep the flaps away, right? So what somebody is having mic open. Okay, so what are its advantages, right? So this is a retractor which has certain advantage.
Yes, sir.
Right? What are the advantages?
Sir, so first advantage is it retracts the tissue laterally, and the second advantage is it is hemostatic.
Right. Why do you say this? So
sir, it will put pressure on the tissues laterally. So the blood vessels, so the blood will, then the hemostasis is achieved by pressure. And because of its self-retaining properties, it will retract the tissues laterally and give us ample of visualization.
okay, right, absolutely correct. So it is also called as post-oral hemostatic self-retaining speculum, right? So it's it's used in the post-oral region. It's self-retaining because it has a locking mechanism, and it is hemostatic because it compresses the flaps, and while compressing the flaps, it actually compresses the blood vessels also, right? So it is hemostatic also. Okay. So what are the in which surgeries you use this instrument?
Sir, otological surgery is like tympanoplasty. During tympanoplasty, we use this instrument while
Just enumerate. So, as Dr. Surendra was telling, whenever the examiner asks any question, you have to limit yourself to the question only. Don't say everything in one go. Let the examiner ask another question. So my question was, what are the indication of this instrument? Where do we use this instrument? So you just enumerate the surgeries where you use this instrument.
Tympanoplasty, mastoid surgeries, and thyroplasty.
Thyroplasty, right? So next question will be then. Your Viva can actually go on to the mastoid surgeries. You can be asked about the
Dr. Ravi.
canal wall.
Dr. Ravi, good evening.
Good evening, sir. Yes, sir.
I want to add one more indication of its usage.
Yes, sir. Yes, sir. Please.
I have used it in lateral rhinotomies.
Yes, there it can be used.
Yes, sir. Yes, sir. Agreed. You can use it in lateral rhinotomy also.
Yeah, for the benefit of postgraduate students, they should remember this indication also. Since they are not doing too many lateral rhinotomies these days, so they are not aware of it.
So even if I want to add, we have used it in while harvesting the facial lata for CSF repair or something in the thigh also.
Yes,
That's
yes.
Right, right. So these are all extended use of this instrument. Primarily, this instrument is used for ear surgeries, and it is called as mastoid retractor. So, are there any complications of this instrument?
Yes, sir. Sir, it can cause extension of the incision that we have given. Excessive extension of the incision that we have given, if unused, if used not improperly used, it could cause extension of the incision that we have given.
Achha, anything else?
Sir, sir, it can also cause trauma.
Yes, it can cause trauma. Basically, the prongs, these prongs are sharp and they can cause trauma. So what type of trauma they can cause during the surgery?
It can cause a tear of the flap. It can cause pressure
Yes.
necrosis of the flaps.
Right. So basically, it can cause tear. And when you are using it for retraction, you have to be sure that the prongs are actually not striking against the tympanometer flap which you have elevated. So sometimes if it gets stuck in the flap, it can cause flap trauma, and the whole tympanometer flap can get teared. Right. So that is one problem which can occur. Can you use this instrument for end-oral incisions? End-oral incisions.
Sir, I'm not sure, sir.
Probably they have not seen it, I think.
Okay. So, I mean, many people do end-oral incisions, and for that, there is a special type of mastoid retractor in which you have one of the sides is actually flat. It does not have these sharp edges prongs. It is a flat, and other side has a prong, right? So what happens, the flat sides actually goes towards the cartilage, and it prevents any trauma to the cartilage. Okay. So
Yes, sir.
if you are not very careful about these prongs, it can actually cause trauma to the pinna cartilage also, and patient can suffer from perichondritis, right? So,
Yes.
and that retractor which is used for end-oral incision is called as Plester's retractor, right? So the Plester retractor actually has a flat, one end of the prong is actually flat. It's a metal, flat metal is used there, and that will help to prevent any trauma to the pinna cartilage, right? So that is one of the variations of the instrument, right? So I think that's all. We can actually, this viva from here, from the mastoid retractor can go towards the mastoid surgeries and indication and contraindication of mastoid surgeries. What are the indications for cortical mastoidectomy or modified radical mastoidectomy or radical mastoidectomy, right? So these can be the further questions on this instrument. So I think we will not go into the mastoid surgeries per se because of shortage of time. We can go to the next instrument.
Right.
Okay, so this is the instrument which I was talking about. So this is the Plester's mastoid retractor, and you can see that one of the prongs has a flat surface, and this is just to prevent the trauma to the cartilage when you are using. And for this is different for right and left. Okay. So you have to identify which side. Sometimes the examiner can ask you which side it is actually, right? So the flat surface actually goes towards the cartilage, and that means that it is the posterior part, right? So posteriorly, it goes posteriorly. The anteriorly is the prong surface, right? Then you can be asked about the different types of end-oral incisions. So do you have any idea about the end-oral incisions which we have? Yes. So different types of end-oral incisions have been described, and it depends on the extent of the lateral extent of the incision. So these are divided by Heermann. So Heermann type A, type B, and type C incisions are there. And what I remember is that Heermann type A is basically end-oral incision which is limited to the canal. It does not come out. Type B actually comes out of the canal and it goes into the incisor terminalis. and does not extend toward the superior part of the pinna. And type C, Hierman type C actually goes all along the pinna towards the superior surface of the pinna, and this, by this incision you can actually extend your dissection to the mastoid also, right? So it is not that you can't do a mastoid surgery via endoral incision. You can actually attempt a mastoid surgery or cortical mastoidectomy also via endoral incision. Only thing is that the incision which you have given will extend from the endoral, from the incisor terminalis all the way above the superior part of the pinna, and then the posterior part, right? So that is the type C, Hierman type C incision. So I think that's all in the Plester's mastoid retractor.
Dr.
Yes,
Ravi,
comments. Yes,
Dr. Ravi, I personally like to use this approach endoral and this Plester instrument
yes,
for
sir.
a narrow canal stepidotomy.
Right. So yes. So this has a role in permeatal approach to middle ear. So if you are doing a exploratory tympanotomy, like Dr. Pasi said, during a very narrow canal, and if you want to do a permeatal approach through the canal approach to the middle ear, then you can use this instrument, and it gives you enough space and exposure for your instrumentation and doing the surgery. So that is also one of the indications for using this instrument.
And type 3 incision, I have seen some people doing cochlear implantation through Viria technique.
Yes, so that is also.
Yeah.
So yes, sir. So in cases of Viria technique, also you can use this instrument, and basically it's a suprameatal approach to the cochlea, right? So in that case also people give incision. It goes through the incisor terminalis and then curves posteriorly towards the superior part of the pinna. So that is also one of the approach. Thank you, sir, for adding that.
Yeah.
You can extend this incision downwards also towards the mastoid tip. If there is extensive pneumatization of the mastoid.
Right.
From 6 o'clock, you can obliquely go down. You can expose the mastoid tip also.
Right. So basically, endoral incision is not very commonly used nowadays because of the fact that there is a scar formation which is sometimes visible. So the incision actually goes in front of the pinna, right? But a postoral scar is not visible at all, and you can do all sorts of middle ear surgeries or even the inner ear surgeries through postoral approach. Postoral approach is a so versatile approach that you can do any sort of ear surgeries by this approach. So there might be limitations by permeatal approach, and there might be limitations by endoral approach, but by a postoral approach, any surgeries of mastoid or middle ear can be done. Okay. So we come to the next instrument.
Yes. And so just to add on,
yes,
the medicines we have also used in TMJ ankylosis.
Right. So there are lots of new indications coming, and I mean it is basically surgeon's choice to use. Basically this instrument can actually retract 2 flaps, skin flaps, right? And it's a self-retaining instrument. So that is the beauty of the instrument. Both the hands are free. So in even like in cases of temporomandibular joint ankylosis, when the incision is given, like it's a preauricular incision with a curvature towards anterior zygomatic extension, you can use this instrument to keep the flap away, and you can then drill the TM joint, right? So that's another indication of using this instrument. Thank you, Raman.
Next instrument.
Okay, right. So can somebody identify this instrument?
Dr. Sudesh.
We have Dr. Sudesh with us.
Good evening, ma'am. Good evening, sir.
Good evening.
Yes, good evening.
Ma'am, it's Farabius periosteal elevator.
Okay, so what is its use?
Sorry, sir.
कहाँ use करते हैं इसको?
Sir, we can use in elevate the periosteal flap in tympanoplasty and also in mastoid surgery.
Okay.
Yes, sir.
So basically, what type of incision you give for over the mastoid periosteum?
Sir, over the mastoid periosteum, that Sir, T shape or C shape?
T-shape. Yes, T-shaped incision is given, right? So basically, when you give a T-shaped incision, it is bone deep.
Yes,
So
sir.
you cut the periosteum along with it, right? So bone deep incision given, and then this instrument is used to elevate the periosteum over the mastoid process, right? Very good. So I mean, if you don't have this instrument, what are the other choices you have?
Sir, we can use also that we can elevate that flap by blade also.
You can
Oh.
use sharp blade
Sharp blade.
also.
Or sir, we can use that cautery. We can
Okay,
put
unipolar cautery.
yes, sir, unipolar cautery. And sir, free edge elevator we can use also.
Free edge elevator. So that is another instrument, but this instrument is a very sturdy instrument, and it can actually can be used to elevate the periosteal flap very easily, right? So, any other questions?
I think the next question can be how to hold this and how do you use this instrument? That is a very important point.
Right. So how to hold this instrument?
I was about to say that.
Right. So that is important.
We can hold this like this position, and we will through pressure by thumb, limited pressure anteriorly.
Okay. Yes, you can use it by. I mean, the thumb is used to stabilize, but you can use both your hands, right? So because sometimes, I mean, it is difficult to use one hand. You can use both the hands and then press this end is actually curved, right? So if you see the tip of the instrument, it is slightly curved instrument, and the tip is sharp. So the concave, the curved side will actually go down over the bone, and then you have to scrape the periosteum, to scrape the bone and elevate the periosteum by moving the instrument backwards and posteriorly, right? So you can use both the hands to stabilize and then do the periosteum elevation.
Yes, sir.
Right. I think we can go to the next instrument.
Yes.
Okay. So what are these? So anybody can answer this?
Dr. Disha, please answer. Dr. Disha.
Good evening, sir.
Good evening. So what are these?
Sir,
I mean, it's written there.
yes, sir. Jenkins mastoid root. Sir,
Okay. So what are its use?
sir, it can be used for sir, during mastoid surgeries for the bones, sir, for elevation, sir, for removal of the bones, sir.
Okay. Basically, it is.
Sir, also.
Yes.
Sir, it also can be used in Calvin surgery, sir.
Calvin luck. Okay.
Yes, sir. And
basically, it is used to remove bone, right? It's a
yes,
mastoid goose. So earlier,
yes,
when we did not have drill, so we used to do mastoid surgeries with hammer and goose, right? So mallet
yes,
and
sir.
goose was used, right? So you can see
Yes,
that
sir.
these are of different sizes, right? So
Yes, sir.
small to large sizes. These are of different sizes, and this is used to remove the bone over the cortex, mastoid cortex, and
Yes.
open the antrum, right?
Yes,
So
sir.
it is a curved instrument. You can see that the tip of the instrument is actually, it is a curved instrument, and the tip is very sharp, right? And this is
Yes,
used
sir.
to open the mastoid antrum. The smaller sizes, I mean, depending on the amount of bone you want to remove, you use the size of the instrument, right? And earlier, the whole cortical mastoidectomy was actually done by this mastoid goose, right? And initially, to open the antrum, you use a larger size goose. And when you have opened the antrum, you can use smaller size goose to make the cavity, the mastoid cavity, much more smoother, right? So that is the use of mastoid goose. And nowadays we are not using this instrument, and we have electric drill available with burrs and hand pieces, right? So what are the complications which can actually occur while using this instrument? So most of you will not be using this instrument, but yes, still for academic purpose, we must know what are the complications which can occur by using this instrument.
Dr. Ravi,
Yes, sir.
I am using this instrument in this day also to remove
Acha, okay.
the spur.
Okay, okay.
Spur part.
Right. Okay. So what complication can occur because of this instrument?
Sir, it can lead to trauma, sir, if
Yes.
it is done excessively, sir.
So what
And-
trauma? Suppose you are doing a cortical mastectomy by this instrument, what can happen?
So there can be trauma to the facial nerve, sir, if there is excessive.
Facial nerve. Acha, और
Sir,
उससे पहले when you are doing a
sir-
cortical mastectomy, उससे पहले क्या हो सकता है?
Sir,
अच्छा देखो, what are the
Sir,
important structures in the when you open the antrum? What important structures you actually encounter?
sir, there can be trauma to the dura, sir. If
Yes, yes, dura. Very good. So
Yes,
when you
sir.
are doing, if you are not taking the temporal line, the inferior temporal line, if you are not taking that into account, you can actually go into the intracranial cavity and you can
Yes.
cause dural damage, right?
Yes.
Or you can also posteriorly we have the sigmoid sinus, so that can actually get damaged, right? So there can be excessive venous bleeding during the surgery, right? So these are the things which can happen. If you go very anteriorly, you can actually damage the lateral sinus canal. Though it is
Yes.
very, very hard structure, but you can actually damage that, or you can also damage the second genu of the facial nerve, which is just adjacent to the canal, or you can dislocate the incudostabilis joint, because that can happen, right? So these are the complications which can occur by using this instrument. Again, your viva can from mastoid goose, it can go into the mastoidectomies and types of mastoidectomies. What is intact canal wall mastoidectomy? What is combined approach tympanoplasty, facial recess approach? All these things, your viva can actually go from mastoid goose to anywhere, right? Depending on how you are leading the examiner, right? So if you are leading the examiner, you will score better marks. But if examiner starts leading you, you will be in trouble, right? So basically, it's just a way to take your viva towards some procedure or some surgery.
If I may add one thing that
yes,
please. We also saw the mastoids being done with this gouge. The smoothness of the cavity is also not there as compared to a drill. So there are some edges which can cause osteitis, and the results may not be that good. Though in an expert hand, it may be as good as a drill.
Right. So people earlier were using this mastoid goose only, and they were doing a fairly good mastoidectomies by using only the mastoid goose, right? Okay.
But Dr. Ravi, there was another instrument with this curate.
Yes, sir. Curate, yes, sir.
Open this, and then with the curate you used to smooth the edges. Smoothen the edges.
Yes.
The curates were also important of different sizes. They were also of different sizes.
Yes, very good. So I will ask you, what is the difference between an osteotome and a chisel? So, and a goose. So that is very, very important. How do you identify an osteotome? How do you identify a chisel? And how will you identify a goose? So goose is very, very simple. You have the instrument in front of you. The goose has curved edges, right? It's like a spoon. It's like a curved thing. How do you identify the chisel and the osteotome?
Sir, osteotome will be comparatively flat, sir.
It is flat, okay. Chisel and osteotome में difference बताइए कैसे होता है?
The chisel, in the chisel, the flat area is comparatively less, sir. Osteotome में ज़्यादा वो बड़ा होता है.
The difference will be at the tip.
At the tip, sir ने बता दिया.
Sir, chisel will be sharp. It will be sharp, a little sharp.
Both the instruments are sharp instrument. It is the bevel. If you see the bevel of the instrument, the edge, it is beveled. So in an osteotome, you have beveled, which is on both these edges, both the sides. A chisel will have single bevel. So it will be flat on one side and beveled on the other side, right? So that is the difference. So what is the difference in use of osteotome and chisel? So can you see this? This is a chisel which has a beveled end on one side only. So chisel is an osteotome has a bevel on both the sides, though, I mean, I don't know if you are able to appreciate or not. Chisel has one side is flat and other side is beveled. But osteotome is like a spear, like an arrow. It is beveled on both the sides. So osteotome is to, like, if you want to cut a bone straight, you will use an osteotome. For example, if you want to do zygomatic osteotomy while doing a maxillectomy, then you will use a osteotome. When you are trying to remove a single small chip of bone, you will use a chisel, right? So that is a difference. So if you want to use you want to just remove a scraping of the bone, you will use a chisel. That is the basic difference between chisel and osteotome. So chisel, you can actually use small size chisel. You can actually use while doing mastoidectomy. So remove small portions of bone. Osteotome, I have already told you, if you want to do a bony cut you want to make, you will use an osteotome, right? These instruments can be used in rhinoplasties also. So if you have different instruments, though it is used in rhinoplasty, you have different sizes of chisels and osteotomes available in rhinoplasty, right? So we'll have these instruments, rhinoplasty instruments, in the later classes. But just to tell you that we have a difference in chisel and osteotome, and their uses are also very different. Okay. So again, you can be asked about the uses. So it can be used in mastoid surgeries, and it can be also used in rhinoplasties. It can also be used in maxillectomies when you are doing when you don't have a powered instrument like a blade or a powered instrument, electric saw. Then you can use osteotomes and chisels to make the cuts. Okay.
If I may add, there some
yes,
of these instruments also have guard. So on one
yes.
side, so to protect the one structure which we want to protect, like in rhinoplasty.
Right. So rhinoplasties, osteotomes and chisels are different, and they have, for example, if you want to do a lateral osteotomy, so that lateral osteotome has a small metallic ball-like projection which you can actually palpate and know where your osteotome is going and what are the line of cut you are making while doing a rhinoplasty, right? So that way we'll be discussing in nasal surgeries instrument. Okay. So anything else you want to discuss in this?
Sir, we are running short of time.
Okay.
Instruments to cover.
Right. So we'll go fast now. We will
Yes,
go
yes.
fast. Yes. So next instrument. Okay. So this is a very important instrument. Can somebody?
Avni ma'am.
Dr. Harsh.
Dr. Avni.
Dr. Harsh, please answer.
Yes, sir. Yes, ma'am. This is a McEwan cell seeker and curate.
Okay.
Yes.
So this is a double-ended instrument. It has a curate on one end and a cell seeker on the other end. So what is the indication of using a cell seeker?
Sir, cell seeker can be used in tympanoplasties and mastoidectomies to.
Tympanoplasty में कब कहाँ use करते हैं cell seeker यार?
Sorry, in mastoid surgeries.
In mastoid
surgeries to.
तो किस लिए कब use करते हैं mastoid surgeries?
Sir, we can use it to see the editus and the antrum. To see how much.
And antrum, अच्छा.
Yes, sir. To see how much bone we have to drill.
Okay. Yes. So basically, when you have reached the antrum and you want to know the bony overhang, so how much bone you have to drill to make a complete good cortical mastoidectomy. So this cell seeker you can insert and you can know what is the extent superiorly, how much bone you have to remove to reach the dural plate. And posteriorly also you can actually insert this instrument to know what is the depth of the sinus plate. Similarly, you can actually use this instrument to know the depth at the tip cells. Okay, this instrument should not be inserted in the editus blindly, because that can actually lead to what? what can it cause?
It can
If you,
cause trauma.
trauma to what? So what is there in the editors?
Sir, incus.
Incus, short process, it is fossa incudis, short process incus is there, right? So if you use it blindly, it can actually dislocate the incus and patient will have hearing loss, right? So that is very important. You should not actually insert it blindly. You can insert it lateral to the incus if you have space. For example, when you are using this instrument during posterior tympanotomy also, you can use. So just to know what is the where is the site of the cell which is leading to the middle ear, right? So during that part also you can use this instrument, right? It is a cell seeker. So as the name suggests, you can actually seek some small cells by this end. The other end is the mastoid curate, right? So what is use of this?
So we can curate out the bone or we can also use it stepidotomy to remove the posterior overhangs.
No. But this end, this curate is of very large size. It cannot be used during stepidotomy. For stepidotomy, you need to have a micro curate. Micro curate, it's a separate instrument. It's a very, very small curate. The size of the curate will be around 2 millimeter, 1 to 2 millimeter. Right? This is a very large instrument, and this is used to remove small bony septas between the mastoid air cells. Right? That can be used to curate, or you can use this to remove some granulation tissues when you are doing a mastoidectomy. Suppose there's a granulation tissue in the mastoid antrum area, you can remove the granulation tissue using this instrument and send it for biopsy. Small bony septas during the mastoidectomies can be used, can be removed using this instrument. Okay. So that is the use of this instrument. Okay. We can go to the next instrument. Mallet. Okay. So basically, anybody can answer.
Dr. Ramya, please answer.
So this is a mallet. While using a gouge,
yes,
the mallet is used to remove bone from the mastoid area.
Right. So mallet, it is used to, along with goose, osteotome, or chisel. All the three instruments will require to be hit by a mallet, and there should be good coordination between the surgeon and the assistant, because the assistant is going to hit the instrument with the the osteotome or whatever instrument is being used. So you should not be very, very forceful while doing using this instrument, and it can cause slippage and even trauma to the underlying structures while using the instrument. So it has to be used very, very cautiously. Okay. So we can go to the next instrument. Okay, so this is another instrument. I think should I just speak rather than ask?
Yes, sir. Now you can.
Dr. Ravi, Dr. Ravi.
Yes, sir.
I think we are showing more of a instrument which are not used frequently these days.
So I think this is also another instrument which is not very much used. This is Lampert curate.
We can just yes.
Right. So this is also again used to remove the bony septa during mastoid surgeries. Again, this is available in different sizes, right? So we can just skip this instrument. We can go to the next instrument. Okay. So these are the different types of burrs available. The mastoid burrs. You can be asked about the type of burrs which we'll be using for opening the mastoid, and type of burrs which will be used for polishing the cavity. So we have diamond burrs, we have cutting burrs, and then we have polishing burrs also available, right? So you should be able to identify this instrument. You can be asked about the size of the burr which is used for stepidotomy, right? So if you see, if you are using a piston of 0.6 mm, then you should be using a burr of 0.7 mm. these small size burrs are available only with skeeter or handpiece, right? And when when you are going to do cochlear implant surgeries, obviously you have to use a smaller size burr like 1 mm burr to do the cochleostomy, right? There are separate burrs available for doing cochleostomies, and these are provided by the kit in the cochlear implant kit, which is available with these different companies. Important point is that when you are using this burr, you should be using the side of the burr to cut the instrument. One thing. Second thing, copious irrigation is very, very important. When you are using a micromotor instrument along with the burr near the facial nerve, it is very, very important that you do a copious irrigation to prevent any heat injury, right? Heat injury is more with diamond burr than the cutting burr, because cutting burr has ridges which will just remove the burr, but the diamond burr has more surface contact with the bone, and it can lead to a lot of heat generation. Okay, so while using a diamond burr near the facial nerve, you should be using a lot of irrigation to prevent any heat injury. Appropriate size of burr is very, very important. When you are using a appropriate size burr during any mastoid surgery, you should note that this burr has a 3-dimensional structure. So the burr is going to cut the undersurface. When you are using the side of the burr, it is going to, you are touching it with some structure. It is going, the undersurface of the burr is going to remove the bone which you want to remove. But the other side of the burr also is moving, and inadvertently the other side of the burr can actually build some other structure. So when you are using it, suppose you are using it in the anterior epitympana, the superior surface of the burr is actually drilling the superior part of the epitympanum, but the under surface of the burr can actually drill the first genu or the facial nerve. So appropriate size burr should be used. You should be able to see what all surfaces of the burr are actually drilling and cutting, right? So that is very, very important. And I think that,
may I add something?
yes, please. Yes, Avni, please add.
Broadly speaking, the classification is of a cutting burr and a diamond burr. So
Right.
both these burrs can be made of different materials. One is stainless steel, the other is tungsten carbide, and the third is titanium. And the diamond burr may be divided into cutting diamond or coarse diamond.
Coarse
So this
diamond,
is the
yes.
broad classification of the burrs, which is usually followed.
Right, right.
Another thing is that for stopping the bleeding, the dry diamond is very useful from the bone.
Right, right. So if you have bleeding from the dural plate or sinus plate, you can just use a dry diamond burr. It will just push the bone dust into the bleeding site, and it will clog the bleeding site, and it will prevent bleeding, right? So that is one of the important thing which has been told by Dr. Nitin.
So the other important thing is that while using a drill, your hand should be stable.
Stable.
The hand should not be hanging like you are drilling. So your hand should be stable with one finger on the somewhere at a stable point, then only drill. Otherwise, you might injure vital structure.
Right. So that is very, very important. You should have some support with the body of the patient or to the table, so that your hand is stable and your burr is not slipping. So slippage of the burr can actually cause trauma to the important structures in the surrounding areas, and most commonly the important structure which can be damaged is the ossicle and the facial nerve, and then you can have the trauma to the dural plate and the sinus plate. So it is important that you should know the good anatomy of the mastoid is very, very important while using this instrument. These are powered instruments and can cause a lot of trauma to the surrounding structures if you are not well versed with the anatomy.
This is also when you are doing a canal procedure like canaloplasty, or you are doing inside mastectomy, inside out.
Okay.
So that's more important. Your hand should be very stable.
Right. Okay, so we can go to the next instrument. Okay, so what is this instrument? This is a Malleus nipper. So what is the indication? So can somebody, tell me, the students, any of you can answer, what is the indication of this instrument? Where do we use and when do we use it? It's a Malleus head nipper. Yes, anybody? हाँ जी, कोई भी नहीं है. Okay, so basically, this is used when you have disease involving the Malleus head, or when this cholestoma is actually going medial to the Malleus head, or it is engulfing the Malleus, or it is going to the anterior epitympanum, and you need to remove the Malleus. But when you remove the Malleus, what happens? The Malleus has another structure, which is the handle, which is actually inside the tympanic membrane. So you can't just pull out the whole of the Malleus, because when you pull out the whole of the Malleus, it is going to perforate, or it is going to cause trauma to the tympanic membrane also. So if the pars tensa is intact, you can actually just remove the head of the Malleus to clear the disease in the epitympanum. And that is the indication. If you have disease in the epitympanum and you want to clear that disease, you can use this Malleus head nipper, and you can just see that it is just like a punch. So if you see a Carrison punch, it's a very sharp instrument. It can cut the bone. Similarly, this is just like a punch. It has a very small edge of there's a small space in which you can actually engage the neck of the Malleus. And you can just cut. So when you cut it, the head of the Malleus will come out. And now you can actually remove the disease in the epitympanum, leaving the tympanic membrane intact, right? So that is the use of Malleus head nipper. Okay, so very, very useful instrument, and it can actually prevent trauma to the tympanic membrane and the tympanometal flap, right?
So if we may add that it is of different for right and left. One is thing like that, and secondly, sometimes it can also be used to nip the distal part of the handle of Malleus also, if it is medialized. Though it is may not be the best technique for medialized handle of Malleus, but it can still be used.
Okay, right. So we can go to the next instrument. Okay, so again, this is a microcurate. So this is the instrument which is actually used to use during stipedotomy, and if you have a good amount of posterior superior overhang, you can use this instrument to remove the posterior superior overhang. This can be also used to curate out the bone in the area of sinus tympani, right? So if you have disease which is going into the sinus tympani, you can use this instrument. This is a small microcurate, a very sturdy instrument, especially used in stipedotomies, right? To remove the overhang, the posterior superior overhang. Okay. Again, this instrument has to be used carefully, because when you are using this instrument, the distal end or the tip of the instrument can actually dislocate the incus while doing stipedotomy. So if you have a dislocated incus, then it is a complication which has occurred, and it is difficult to manage sometimes a dislocated incus, right? So careful instrumentation is important. The curate should be sharp. If you have a blunt curate, then don't use it, because a blunt curates can actually slip and can cause trauma. So a sharp curate is mandatory while removing the posterior superior bony overhang during stapes surgery.
Another important point about this instrument is how to use, which direction it should be.
Okay, yes. So yes, so this you should use from inside out, right? So you engage this instrument in the bony overhang and curate from inside out, come out from medial to lateral. It has to be used medial to lateral, and
or it can be above downwards, like this, rather than going towards the facial.
Right. So important thing is to use it in a controlled fashion, and should avoid any trauma to the incus and to the facial nerve also. So I've seen one patient who underwent stipedotomy, and there was a trauma to the second genu while curettage. So that should be avoided, right? Okay.
And so just to add on, we should stabilize the head. We should ask our
assistant to stabilize
the head.
Right. Okay. Next, we can go to the next instrument. Okay, it's a curved pick. So curved needle or a pick. This has various uses. This can be used. One of the important uses is basically to elevate the annulus. So when you are entering into the middle ear while doing tympanoplasties or even exploratory tympanotomy, it is a sharp instrument, and you can easily insert into the sulcus and elevate the annulus, so that you don't do any trauma to the tympanic membrane. So while elevating at the level of annulus, actually you can go lateral to the annulus and cause a tear. So that you can avoid by using this curved pick. This can be also used during graft placement. If you are using temporal fascia or a this tracheal pericardium, you can adjust the graft by using this curved instrument. It can be also used to dislocate the IS joint. So if it is a curved needle, it can actually be used to dislocate the IS joint. It can be used to remove the mucosa or dissect off the cholestoma over the stapes footplate area or from the suprastructure, right? So you have to be very gentle while using this instrument.
You can break the fibrous bands, mucosal tags.
Yes, mucosal tags and fibrous bands. It has a multiple uses in the middle ear, right? So depending on the curvature, this can actually be used to remove disease from the sinus tympani also, right? So, or carefully remove the cholestoma matrix from the ossicles, from the suprastructure or from the facial nerve or from the stapes footplate area, right? Or it can be sometimes used to remove the cholestoma matrix from the lateral semisugnal fistula also, right? So gently you have to use this instrument under magnification. Okay, next instrument. Okay, so this is another instrument with straight needle. So again, it has almost similar use, but this can be used to check for the mobility of the ossicles also, and it has almost similar use of a curved needle, right? I think we can go to the next instrument. Okay, this is a circular knife, right? And this is a Rosen's, also called as Rosen's knife or a circular knife, and this is a very good instrument to give a incision or Rosen's incision or a tympanometal flap incision. So when you are going to do a myringoplasty or tympanoplasty, you have to give a tympanometal flap incision, and the incision, you can be asked about Rosen's incision. What is Rosen's incision? Rosen's incision starts from 6 o'clock position to the 12 o'clock position, and laterally it goes to around 6 to 8 millimeter, right? So it should be a sharp instrument, and when you are using this instrument, you have to cut the flap bone deep, go bone deep with this instrument. And this instrument sometimes have small holes also there, so that it can be used to elevate the flap also, and you can use suction over this instrument, right? So it has many surgeons use it for giving incision as well as for elevating the flap. And once they reach the annulus, you can use this curved needle to elevate the annulus. Okay, so that's the use of this instrument.
To add on, now we have the for endoscopic surgeries,
Right.
we have the suction instruments, micro instruments.
Yes, so for endoscopic surgeries, endoscopic ear surgeries, you can have a very small suction attached to this, which can actually help to remove the blood while doing endoscopic ear surgeries. Okay, next instrument. Okay, so this is a flag knife, or it is also called as radial knife, also called as Plester's knife, right? So this incision is used to give a radial incisions. So when you are using, when you are giving a incision, the radial incisions, like from 6 o'clock position laterally to 6 millimeter, and then from 12 o'clock position laterally to 6 millimeter, this incision can be given by using this radial knife. Many of the surgeons, can give incision with circular knife also, right? But a radial knife can be used to give radial incisions, and it can be sometimes used to elevate the annulus also annulus along with the tympanometer flap when you are elevating beyond 6 o'clock position. So sometimes this can be used to elevate tympanometer flap also. Okay. Again, this instrument should be sharp instrument so that you don't cause trauma to the flap, the tympanometer flap. Okay, next instrument. This is a sickle knife. Sickle knife also has almost similar uses as of curved pick, right? It's almost like a curved pick. Again, this can be used to elevate the annulus. It can be used to remove the cholestoma matrix from the middle cleft. Again, this can be used to give incisions in the tympanic membrane while doing Grommet insertion. This can be used to remove this cholestoma matrix and granulation tissue, cut the fibrous bands. In revision surgeries, you might have some bands of fibrous band between the ossicles and the medulla, so that can be cut by using this instrument. This can be also used to
freshen the edges of the perforation.
Freshen the edges of the perforation. Yes, very important. This I missed. This can also be used to cut the tensor tympani tendon. Sometimes when you are doing osteoplasty, you can actually do a relocation, malleus relocation of the posterior relocation of the malleus. So that can be done while cutting the tensor tympani tendon, right? So it has got multiple uses.
Some complication can occur with this instrument that can be
right.
So, while going inferiorly, if there is high jugular bulb, you might injure that. So that should be
right.
So also superiorly stapes and
right. So while using this instrument over the facial nerve, we should be very careful. The facial nerve can be distant in the second genu area and over the area of the foot plate. In that middle, in the posterior part of the tympanic portion of the facial nerve can be distant, and if there's a cholestoma or a granulation tissue over the facial nerve, you have to be very careful while using this instrument. Okay. So what next?
Discussed.
Okay, so this is a ball probe. Okay, so this is a ball probe which can be used to probe the middle ear, well, or you can mainly basically to know the extent of the disease which is going, to know the extent of the sinus, depth of the sinus tympani, right? So in the depth of what is the depth of the sinus tympani, you can know. It's a relatively blunt instrument, so it can be used in the editus also. It can be used to know what is, if the disease is going into medial to the ossicles or into the anterior epitympanum. So basically to know the extent of the disease, this is used. It can be,
you can say.
basically, yes. So that is the use. You can also use it to know the ossicular mobility. आप इसको touch करके you can check the mobility of the ossicles. So that's the use. Next. Okay. So this is a flap elevator. People use flap elevator for elevating the flap. Many people use only this circular knife. For example, like I only use circular knife, don't use this flap elevator. I use circular knife. I'm very comfortable with circular knife to elevate the flap, but this instrument can also be used to elevate the flap. This has another use while adjusting the graft, because it's a very blunt instrument. You can use this instrument to adjust the graft, push the graft under the anterior edge, right? And sometimes to push the gel foam medial to the tympanometer flap and to the tympanic membrane graft which you have done, right? So this instrument can be used while graft placement. I find it useful. Okay. Next. So these are all middle instrument. This is the ball probe, then the circular knife, the radial knife, the flap elevator, and the sickle knife, right? I think we have all discussed this. We can go ahead.
Measuring.
So this is a measuring rod. So can somebody tell me, all the 4 students who are there, can you tell me how do you measure the length of the piston? So that is very, very important question. And when you are asked in your exam, this, I mean, when you are asked about this instrument, definitely this question will be asked, how to measure the length of the piston. So can somebody answer it?
Sir, we measured
Sir,
it by but
from the
distance.
So from the footplate to the long process of the incus, from the meters of the incus, we can
from the
measure the
footplate
piston till the incus.
इंकस में कौन से पार्ट से लेते हैं और कहां से लेते हैं?
मिडिल पार्ट होते हैं.
Medial part, sir.
Medial part. Okay. So we have the, very good. So absolutely correct. So what do we measure and what do we do then? So suppose it is 4.5.
So we will add 0.25 mm.
Okay.
To add that footplate area.
Depth. Very good. So Dr. Harsh has told correctly. We need to measure from the footplate till the medial surface of the long process incus. So that will give you a length. Suppose it is 4.5, you have to add 0.25 for the thickness of the footplate, right? So the correct size of the piston will be 4.75. Can you tell me what is the thickness of the footplate? What is the size of the footplate? Size तो पता होना चाहिए. And where do we do a stepedotomy?
So stepedotomy, sir, in the middle and the inferior part.
Okay, I take it. Generally, it is done in the posterior 1/3, but posterior 1/3. But the new Scotman actually says that it should be middle 1/3, inferior part में कहता है वो. Okay, so can you tell me the size of the footplate? It's around 2 into 3 millimeter. And the thickness actually it varies. It varies from 0.15 millimeter to 0.3 millimeter. Okay, so we take almost average like 0.25 mm is added to basically take the account of thickness of the footplate. Because if you don't add that part, thickness of the footplate, the piston will come out. So we want the piston, the medial end of the piston to go inside the footplate. Is it okay? So that is why we have to add 0.25 millimeter. So am I clear?
Thickness can be more when there is a obliterative focus or a thick disc focus, what we call.
Right. So
that time the thickness can be.
Right. So if you have an obliterative focus, when will you measure the footplate? When will you measure the size of the piston?
After blue lining of the vestibule?
Yes, yes. So don't measure at the start of the surgery. You have to blue line. You have to remove the obliterative foci completely. And when you have made it blue lined, then you measure the thickness and then you do a stepedotomy. Okay, right. That is very, very important. Okay. So I think that's all in the measuring rod, because if you are given this instrument, you will be asked about the length of the piston, and you can be asked about stepedotomy per se. You can be asked about the different types of pistons. You can be asked about what is the instrument which is used in conjunction with this measuring rod. इसके साथ में एक और इंस्ट्रूमेंट यूज करते हैं. Yes.
So stepedotomy jig.
Jig. So that is important, because when you have measured the length, so you have to cut the length of the piston accordingly. Like if it is 4.75, you insert it in the 4.75 millimeter slot and then cut the lower end of the piston, and that will give you the size of the piston which is required for this patient. Okay, so zig is used in conjunction with this instrument. Okay.
Sir, I want to add something.
Yes, yes.
Sir, actually, there are two types of measuring rods. This is house measuring rod, in which we have a single marker. So house, they have a single marking. We can see here. So with the varying lengths of 4 mm, 4.5 or 4.25 mm. While in Shia measuring rod, there are 3 markings. At different distance. Yes, it is a single instrument, and in the house we have a different instruments with the different markings. So this is house.
So what we have, I mean, I am comfortable with is a Shia's type, which have 3 markings. Yes. And it is actually you must measure the marking also, because it can be different. So you just insert this into the jig and see what is the first marking. So probably it is 4.25, then 4.5 and 4.75. So that is the usual thing, but you must measure it and confirm it that it is the first knob, metallic knob, is at what distance. So you should use it in conjunction with the jig.
Okay, with this instrument, the whole steppies chapter can be discussed.
Yes, the whole steppies, and steppies is very, very
indication of stapedectomy. What are the other options? Hearing aid, sodium fluoride, indication, contraindication, all those things can be.
Right. Absolutely correct, sir. Basically, the whole steppies can be asked, and it is very, very favorite topic for exam. So almost, I mean, nobody is going to ask very simple basic tympanoplasty or meringoplasty. If you happen to pick this instrument, your viva will actually go on stapes surgery. So you should be very well versed with stapes surgery. Okay.
If you know stapes, pick up this instrument.
Yes. Next. Okay, so this is a micro burr, or this is also called as Larkin's burr. If you don't remember the name of the surgeon, it doesn't matter, but you should be able to identify that this is a micro burr, and this is actually used to smoothen the edges of the stepedotomy. So once you have used a perforator, so there are different sizes of perforator available, 0.6 mm, 0.7 mm, and we have perforator of 0.5 mm also if you want to insert a 0.4 mm piston. So there are different sizes. Once you have made a perforation with using a perforator, you can actually use this micro burr to actually smoothen the edges of the stepedotomy which you have made, right? Nowadays, most of the surgeons, they are using Skeeter. So Skeeter is a very good, wonderful tool to do a stepedotomy. It has different sizes of burr available. The handpiece is very, very light, and it has a curved burr. So there's a curved burr, so it will give you an excellent vision because of the curvature of the burr. Because this is a straight instrument. When you are using a straight instrument, your hand will obstruct the view. But if you are using a Skeeter, it's a curved burr, so it will not obstruct. The hand will not obstruct, and you will have a good view of the foot plate and where you are drilling also. So Skeeter can be used, and people also use laser. When you are using a micro burr or a perforator to stepedotomy, it can cause trauma to the foot plate. It can cause trauma to the membranous labyrinth. It can cause floating foot plate, right? All these complications can occur. But if you're using a laser is a no-touch technique. So you're not actually touching the stapes foot plate at all. Laser is fired from a distance, and it will cause a evaporation or small area and leading to stepedotomy. So that is a no-touch technique, and it's the safest way to do a stepedotomy. But if you don't have a laser, obviously you have to use a perforator. Okay. Next. Okay, so this is a perforator, right? And if you see the picture is not very clear, but if you see the distal end of this instrument, the tip of the instrument has a small margin, and that will prevent the whole perforator going into the middle, to the inner ear. So it has small edge. So it will just the distal part, the tip of the instrument will only go into the foot plate, right? So it is again available in different sizes, and you must use it very, very gently. Don't use excessive force while using this instrument, because if you use excessive force, it can actually go inside the foot plate. It can cause dislocation of foot plate, and it can also cause trauma to the membranous labyrinth. So while using this instrument, you have to just keep this instrument over the foot plate and rotate it gently. Don't put extra pressure. So by finger rotation, you just rotate and to and fro, and just that will, the weight of the instrument is sufficient to make a small hole in the foot plate, right? So that is important. Don't use excessive force. It can cause trauma to the membranous labyrinth, and it can also lead to floating foot plate. Anything else, sir, you want to add? Okay, next. chlorotomy scissors. Okay, so the chlorotomy scissors are these scissors are used to remove the anterior and the posterior crura. These are different for right and left side, right? So right has basically this instrument, when you are using, the curvature should be, the concave side should be anteriorly, so that you can actually go and cut the posterior crura. So the instrument is different for right and left, and this instrument is used to cut the posterior crura. The crura should be cut just at the attachment with the foot plate. Don't cut it too laterally. It should be cut flush with the foot plate. And once you cut the posterior crura, the anterior crura actually breaks on its own, and you can remove the whole suprastructure very easily. If you don't have this scissor, chlorotomy scissor, you can actually use a sharp pick. And what you do, sharp right angle pick can be used. What you do, you just scrape the posterior crura with this sharp needle, right? And keep on scraping till it gives way, right? So that is another way to remove the posterior crura, and the anterior crura will come out on its own because it is very thin and slender. Apart from using right angle pick, you can actually use teeter to drill the posterior crura, or you can also use micromotor with very small point, 5 mm, 0.6 mm burr, or you can use laser to drill the posterior crura. There are two types of laser which can be used in stapes surgery. One is the carbon dioxide laser, which is fired from a distance, and you can also use a handheld laser, which is passed through the fiber. So you can use a fiber laser also, and you just have to keep the tip of the laser fiber just very close to the crura and fire it. You don't have to touch it, just keep it very close to the posterior crura and fire the laser. It will evaporate the posterior crura and you can remove it, right? So that there are different ways to remove the posterior crura, and I have told you that. Using this instrument, you should be careful that you don't dislocate the incus. The whole stapes surgery is very, very delicate surgery, and you have to be very careful while using the instrument into the middle ear. Try to be as atraumatic as possible and try to avoid any trauma to the incus. Next.
If I may add the word scraping instead of word scraping, we can better use the word scoring.
Scoring, right? Okay. Yeah. Very nice. Thank you. Thank you, Dr. Nithin. Scoring is a good word, right? So you can just score it with the right angle pick. Okay. Next. Okay, so this is a cup forceps, very commonly used to remove granulation tissue or take a very small biopsies from the middle ear. Can be used to insert cotton plagiates, gel foams, right? And to hold the ossicle which is eroded, and you want to remove the ossicle, you can use this forceps to hold the ossicle remnant and remove it. I think that's all. We can go to the next instrument.
One should be careful while removing the granulation over the facial nerve.
Facial, yes.
You might be pulling the facial with this cup forceps. So that is important.
So this is a micro scissors. Okay, so the micro scissors can be used to cut the mucosal adhesions. Also, it can be used to sometimes when you are raising the flap, the superior part of the flap is very, very thick, right? And sometimes you are not able to cut it with the radial knife or with the surgical knife. Then you can actually use this instrument, this scissor, to cut the flap also, right? Sometimes what happens, the flap is very, very thick. The tympanometer flap, the posterior part, which when you are elevating, you might have to trim or decrease the thickness of the flap. Then you can use this instrument and try to reduce the thickness of the flap by cutting the excess amount. Do not cut the epithelial part. You have to cut the fibrous part, which is posterior along the bony side, right? And then you can also use it for cutting the mucosal adhesions when you are doing a revision surgeries, right? So these are uses. Next.
Other use of it can be for cutting the stapedial tendon also.
Yes, a stapedial tendon. But for stapedial tendon, I would advise you to use a smaller scissor, very small,
Yeah.
because this is a very large micro scissors, but a small size micro scissors can be used to cut the stapedial tendon.
Right, right.
Crocodile forceps. Okay, so this is another very good instrument to. I use it for inserting the graft also. I use it for removing the margins of the perforation. So when you have perforated the margins, and you are using a sickle knife or a sharp curved pick to remove the margins, right? So to hold the margins and remove it, you need to use this instrument. And very often what happens, this instrument is not working, it is not holding. So you should have a good quality cuff forceps. Don't use it for holding the cotton pledgets, etc., because the tip will get damaged. So a good quality crocodile forceps is must, because then only it will be able to hold the mucosal tags or the tympanometrial flap or the margins of tympanic membrane. This can be also used to remove disease in the sinus tympani area, or there is a mucosa or the cholestoma which is going into one of the cells. Then also you can use this instrument to remove that. Grome insertion, yes, very important. Grome insertion it is very, very important. You can use this instrument. Okay, next.
To hold the piston also.
To hold the piston, yes. So there are multiple uses of this instrument. It's a very universal instrument. Universal instrument. Without this, you can't do any good ear surgery.
So we have a last instrument now.
Okay.
Otology.
This is jig. So
and these are microsuction tips.
Microsuction tips, right? So again, jig, we have already discussed about this jig. So there are different holes available, and each hole is measured. It is 4.7.75, then 4.5. So there are different sizes available, and you can insert the piston. So there are two sides. So there are two series of holes, if you see. So this is for one of the holes is larger and one of the hole is smaller. So it is basically for 0.6 mm and 0.4 mm pistons. And you can be asked in the exam, what piston will you use, 0.6 mm or 0.4 mm, and which piston has a better hearing results after the stapes surgery. So you can use both the pistons. It depends on the availability and the surgeon choice. 4.4 mm piston can be also used, and 0.6 mm piston diameter can be also used. There is not much difference in the hearing gain after the use of these two pistons, right? So there have been numerous studies, and they found that there is not much difference between the 0.4 millimeter or 0.6 millimeter pistons. Okay, so that's all. Next.
So this was the last instrument from the.
Okay. So anything
in the chat box which needs
anything in the chat box. Let's see.
Nitin,
what is
sir, any queries?
Dr. Nitin, and I will also request Dr. Avni to please
one question
comments?
which I can see is, what is the difference between scoring and scraping?
Okay, so
right. So Dr. Ravi, if you'd like to answer, or
right. So scoring, as Dr. Nitin has told, we have to score the posterior crura to remove it, right? Scoring with the right angle pick, and scraping is like when you are scraping is basically when you are elevating the tympanometrial flap. You have to actually go right till the bone and scrape it, so that you are elevating the tympanometrial flap without any trauma. It should be gradual, it should be slow, and it should be meticulous elevation of the flap.
So just it is a more of a scientific word, scoring. Means
right.
You have to just gently move your hand over the crura, the posterior crura. While scraping is just removing the disease. It can be for many multiple uses can be there with the word scraping.
Right.
English literature says the same thing also.
Achha. Okay, so Dr. Avni, you have any comments?
I would like to add there's a piston holding forceps also.
Right, yeah. Yes. This is a piston holding forceps.
Crimping forceps also.
Crimping forceps also there, right? So
Another
they might be
ossicle
available in
holding
some of the
forceps.
institutions.
Ossicle holding forceps also there.
Ossicle, yes, we missed Raman. We missed ossicle holding forceps.
Yes, sir. There were
So
many
ossicle-
more
it is
instruments.
there. It is there in our OT, and many times, I mean, if you are reusing the incus, suppose the incus is the long process of incus is majority of time necrosed, you can actually refashion it and use it for a material as a ossicloplasty. So when you are refashioning it, you need to hold the instrument with ossicle holding forceps, right? So that's there in our OT. I think we should add this in the presentation. Anything else?
I would like to add that each of these micro instruments also, the complete name is associated with a surgeon. Like, for example, sickle knife is Shia, the curved and straight pick is by Cawthorn. So these also the complete name the students should know.
Okay, right. So, I mean, if the student is able to identify the instrument correctly, and if he is not able to name the scientist or the surgeon, I'm not going to cut his marks.
That is for distinction. That is for distinction.
That is for distinction. Yes. For example,
No, another. I don't know whether this is present in some institutes. There is a Zollner set also.
Zollner set, yes. So the Zollner set is basically handheld instruments, and these had thumb rest. All the instrument had thumb rest. We used to have a Zollner set in our OT, and slowly all the instruments have
gone. Yeah,
have gone because they became blunt, and subsequently we discarded them. But we now have the Rosen set, which is a long instrument. All the Rosen sets, the Zollner set had an advantage that it is not the hand doesn't obstruct your view. But again, the Zollner set, it is difficult to use. I have used it.
Yes.
I'm not very familiar
Comfortable
with the
to use.
instrument and comfortable with the instrument. I'm using a Rosen set only, and all these are long instruments with a tip.
Right.
So,
yes,
sir, any last comments, and then we can probably wind it off.
Yes, sir. So thank you very much, sir, for your interesting talk. So I can see Dr.